This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is our Advocacy In Action feature, making our 15th appearance at ASCO and one of our very best.
Recently, AMCAP and IASLC came out with some guidelines on getting anyone with adenocarcinoma, non-small cell lung cancer, getting your tumor tested. And I think that's kind of what we're talking about and referring to in this discussion. And I know the question that I have and the issue that I have is, right now there are two mutations that have been identified, EGFR and ALK, both which have FDA-approved treatments to be associated with them. So basically the recommendations in the guidelines are basically you should be tested for ALK or EGFR mutations. My question is, and my challenge is, so there are, I think last I heard, up to 230 identified mutations and more coming. And I just was in one session just now that showed that there's only 37% now of the patients that are being identified with no identifiable mutation yet. But even at that, there's probably at least 10 to 15 mutations that there are active clinical trials going on. That people, if their tumor were tested, and ROS1, RET, KRAS, I mean, all these other mutations. So why are we just stopping at ALK and EGFR, especially given in lung cancer in particular, tissue is very valuable. So once you use that tissue to get tested, there's not necessarily a whole lot of it left, and it's not easy to get more. So if you have the tissue and you're gonna get it tested, do you just stop at the EGFR and ALK? Or should we be testing for more than EGFR and ALK? And that information should be given to the patients. So not only should they know their histology and their stage, they also should know their genetic mutation of their tumor. So that would be my question.
I think the issue is that what you say exactly, the tissue. So a lot of the lung cancer, actually 2/3 of lung cancer patients actually are advanced stage lung cancer patients. So usually they are made, the biopsy are made, the diagnoses are made on biopsy tissues. And over the years, I think there has been sort of a trend to get less and less tissue to get the diagnosis, because we can now make a diagnosis on cytology specimens if we don't really need that much material. So this has been sort of a practice. And then so when you have a small amount of material, then you actually sort of have to prioritize what kind of test do you want to do, that you want to get the information which is immediately sort of useful, right? So that's part of the reason that I think the testing we should be only limited to prioritize to those which has the mutation that we know that there's specific drug that can be sort of effective, right? So of course, I think down the road, I think we want to have more and more of this information, and I think the technology is also evolving, and I think the technology is evolving now that so that less and less tissue can be sort of used for the technology that can more and more information. So I think it's evolving. So at this time, I think because of the limitation of the tissue and also the cost, I think that that's why I think we are prioritizing only the EGFR and ALK at this time. This is my view, I think.
I think you hit on the holy grail is taking someone, regardless of what cancer they have, but lung cancer, and trying to understand what it is that's driving that cancer. And right now, genomic sequencing is one way to interrogate or look at that cancer. and we can look for, maybe 450 genes or do the whole genome. We have the technology that can do that. The question is, what are you going to do with the information? So I too agree. Every patient you should try to learn as much as you can if you're prepared to take the next step and use that information to pursue a clinical trial. So to get back a report that has 225 pieces of information that you can't do anything with outside of a clinical trial is not going to be of help to anybody. So EGFR and ALK, we know what to do with that. ROS1, as you point out, is very exciting, and we probably do know what to do with that now, but we don't know what to do with KRAS, we don't know what to do with MET, we don't know what to do with BRAF. We have drugs that look exciting, and you want to marry a BRAF mutation with a BRAF inhibitor, but that has to be done as part of a trial.
Because tissue is hard to obtain, if you don't test for what you're capable of testing for, even if you don't have a solution, you may not have easy access to tissue later. So while the information can't at first be applied, is it still not useful?
Well, I'm on your side on this issue. I could test somebody today and maybe use that information 6 months from now to get them on a trial. I do want to get back to this issue of tissue is the challenge of it. It's a precious commodity, but it's for most patients you can have a conversation about these important things and get a new biopsy. So I'm not saying it can be done in everybody, and sometimes you do it and there are complications, or you go to a lot of trouble and it still comes back with insufficient tissue. But in my experience, and I think it's true for a lot of people, when you pursue a second or third biopsy for those intentions, patients are excited and willing to do that, and especially if you have a conversation about the pitfalls of that process. Getting more tissue in lung cancer is doable. We're doing repeat biopsies all the time now, every week. It's a typical conversation in a clinic to say, Mrs. Smith, do you mind if next week I get you over for a guided biopsy? It's an outpatient procedure. There are some risks, but the goal is to use that information to help you with some potential options down the road. And I haven't yet met a patient that says they don't want to do that.
But I would still say, if you can do it up front,
Absolutely. Yeah.
that would be the first choice.
Yeah.
And then, let's say down the road, and you were out of tissue and you need it to confirm something or whatever, you can do that.
I think we should get as much information up front as possible. As I say, it is a technology issues. I think that, so many centers now, we do have the technologies now, what we call the multiplex sort of testing. But they're not all centers have that yet. So I think it's if you have those centers that have the multiplex platform, I think it makes sense to have those testing done. Because actually with those multiplex platform, actually you need almost the same amount of material to do one test and to do the whole thing. So so I think but not all the centers have that yet. So.
Ming works at a premier cancer center that, like a lot of academic centers, have access to this technology. But I work, I think, at premier community center, and we offer this testing, and we're not unique in that. It's not going to be long that many oncologists are going to leave this meeting and say they want that at their center, and there's plenty of laboratories that will be offering the service. So I think you're going to see more and more opportunities in your backyard.
Yeah.
Thank you to this panel. Thank you to all of you. I hope you have a great rest of your meeting.
Thank you.
Thank you.